In this lecture, we will discuss arrhythmogenic right ventricular dysplasia, including its pathophysiology, clinical symptoms, EKG and imaging findings, as well as potential treatment options. Subtle differences in QRS, ST, and T-wave morphologies generally represent benign variations. However, in some cases, these changes may be diagnostic clues to identify rare inherited disorders that are associated with an increased risk of sudden cardiac death. These inherited disorders can have unique underlying mechanisms and presentations, but there are a few characteristics that they share, and we should know these. These characteristics include an increased risk of sudden cardiac death. They are the result of a functional mutations in ion channels, ion channel accessory proteins, or myocardial structural genes. And they mostly appear in the absence of overt structural heart disease. And lastly, they have characteristic EKG patterns. And it's the characteristic EKG patterns that help to differentiate these inherited arrhythmia disorders. So in this lecture, we're going to focus on arrhythmogenic right ventricular dysplasia. So arrhythmogenic right ventricular dysplasia, which is also known as arrhythmogenic right ventricular cardiomyopathy, is predominantly a genetic disorder of cardiac muscle. It is characterized by pathologic fibrofatty replacement of the right ventricular myocardium and can occasionally involve the left ventricle as well. This myocardial disruption from fibrofatty replacement often leads to the development of non-sustained or sustained ventricular arrhythmias and an increased risk of sudden cardiac death. So if you look here, you can see that. So here's our right ventricle. This is our left ventricle. Okay, so as the name implies, we're looking, this is dysplasia of the right ventricle. Okay, and again, the arrhythmogenic, genic meaning the genesis or formation of an arrhythmia. So it's one way you can remember it, and that's one of the main things we see here. Okay, so here's our right ventricle, and we're having these fibrofatty deposition in this area here. So if you look here, these are fat cells, okay, so fat cells within the right ventricular wall, and we'll see that these fat cells, you can have these reentrant VTAC that can develop and get these sort of arrhythmias that develop, okay, and we'll talk about that shortly. So you have this fibrofatty replacement of the right ventricular myocardium, and that can lead to these paroxysmal ventricular arrhythmias, as well as that risk of sudden cardiac death. So arrhythmogenic right ventricular dysplasia has been associated with up to 20% of all sudden cardiac deaths in individuals under the age of 35 years. And it's considered to be the second most common cause of sudden cardiac death in young individuals after hypertrophic cardiomyopathy. Oftentimes, this disorder is inherited in an autosomal dominant fashion with variable penetrance and expression. There's also an autosomal recessive form called the Naxos, okay, the Naxos disease, which is associated with hair and skin changes, likely woolly hair, as well as this palmoplantar keratoderma that you can get. So just remember the hair and skin changes, and this is the autosomal recessive form of this arrhythmogenic right ventricular dysplasia. Now, this Naxos disease, this disorder is more common in males. Actually, just arrhythmogenic right ventricular dysplasia in general is more common in males. Okay, there's about like a 3-to-1 male to female predominance. Okay, and as well as in patients or people of Italian or Greek descent. So if you're Italian, if you're Greek, you have a greater likelihood of getting this. But still, it tends to affect about 1 in 5,000 individuals overall. Okay, so that's just a little bit on the prevalence. So how can we make the diagnosis of arrhythmogenic right ventricular dysplasia? Well, there's actually no single diagnostic test. Instead, the diagnosis is made using a combination of clinical features, EKG findings, as well as some imaging. So let's look at the clinical features first. So patients tend to experience symptoms as a result of ventricular ectopic beats or sustained ventricular tachycardia. They typically present with palpitations, syncope, or cardiac arrest precipitated by exercise. In fact, the first presenting sign may be sudden cardiac death. Typically, patients will have a family history of sudden cardiac death, and over time, if these patients survive, they tend to develop features of right ventricular failure, which may even progress to involve the left ventricle and cause biventricular failure and dilated cardiomyopathy. Okay, so those are the clinical features that these patients tend to experience or can develop. Now let's take a look at those EKG features. Now the most specific finding that you will see and hear about, and it's seen about 30% of these patients with arrhythmogenic right ventricular dysplasia, is this epsilon wave. And the epsilon wave is a small positive deflection that tends to be buried in the end of the QRS complex. Okay, so here we have our epsilon wave, and you can see that here. All right, this is the epsilon wave at this end of our QRS complex. This here is our QRS complex, and you can see this is the epsilon wave that we're pointing out. Okay, so I'll erase that so you can see that it's highlighted there and circled in red. Okay, and it's present in about 30% of these patients. About 85% of patients have T-wave inversion in leads V1 through V3, and nearly all patients have prolonged S-wave upstroke of greater than or equal to 55 milliseconds in leads V1 through V3. In those same leads, there may also be localized QRS widening to 110 milliseconds or more. Okay, so these are the other features in, again, V1 through V3. Here are these leads, these right-sided precordial leads, and you can see there's T-wave inversion. This is our T-wave here. You can see that it's inverted. You can also see that this S-wave upstroke, which is from, here's an R wave, and this is our S wave of our QRS complex. I'll erase this so you can see it. So this is the S wave, and it's from the beginning of the S wave, which is marked here, to the end of it, which is this point here. We're saying that that is greater than or equal to 55 milliseconds. So remember, one small box is 40 milliseconds, and you can see it's somewhat prolonged in this case. You can also see QRS interval widening, okay, up to 110 milliseconds or greater. So the QRS interval is from the beginning of our QRS complex to the end of it, okay, so that interval there, and you can see that it's certainly reaching 110 milliseconds or greater. So I'll erase that so you can look at that without any markings on it. Okay, so those are the other features, and some experts suggest that recording the EKG rhythm strips at double the speed and the amplitude can enhance the detection of some of these EKG features. Now lastly and importantly, you may see paroxysmal episodes of reentrant ventricular tachycardia with a left bundle branch block morphology, and this is because VTach is originating from the abnormal right ventricle. Okay, remember we said this is right ventricular dysplasia, so it's mainly affecting this right ventricle. Obviously it can move to involve the left ventricle, but if you have the right ventricle affected, you get these fat cells that are in there, and you can have these reentrant arrhythmias that develop around them. Okay, and imagine that you have these arrows here that are just moving around this, so you have this reentrant ventricular tachycardia originating from the right ventricle, so we call it reentrant right ventricular VTach, okay, and it has this left bundle branch block morphology, as you can see here in these right precordial leads. And why is that? Well, it's because it's originating from here in the right ventricle, okay, and then it's spreading towards the left ventricle, okay, so it's like we have the left bundle branch that's blocked and it's heading there late, but in this case, because it's originating in the right ventricle, but in this case, it's not due to left bundle branch block, but more so from this reentrant VTach that's originating from the right ventricle. Okay, so hopefully that makes sense there. So let's take a look at some of the imaging now. So echo or echocardiography is typically done first and may reveal a dilated or hypokinetic right ventricle with prominent apical trabeculi and dilatation of the right ventricular outflow tract. You can also do cardiac MRI, and this is more accurate and tends to demonstrate structural and functional features such as fibrofatty infiltration and thinning of that right ventricular myocardium. You can also see right ventricular dilatation and aneurysms, regional wall motion abnormalities, and even global systolic dysfunction. Other imaging modalities that can be used are when you don't have cardiac MRI that's available, you can use CT scan as well as a right ventricular contrast angiography. In addition, a definitive histological diagnosis can be made via endomyocardial biopsy, or if it's too late, at autopsy. Okay, So that is the clinical EKG and imaging findings. You can also refer to the 2010 task force criteria if you want more detail, but just a warning before you look at it, it's very detailed and complicated. All right, so let's move on here. Now, in order to assess the risk of patients with arrhythmogenic right ventricular dysplasia, they are considered to be at high risk of sudden cardiac death if they have any of the following. Okay, and you can see those listed here. We'll go through them. So first, if they have any one of these, if they have a history of syncope due to cardiac arrest, okay, that means that they're at high risk of sudden cardiac death. If they have recurrent arrhythmias that are not suppressed by antiarrhythmic drug therapy, that puts them at high risk. Or also if they have a family history of cardiac arrest in a first-degree relative, that also puts them at high risk, okay? Now lastly, let's just mention a few words on treatment. For those patients that do not fall into the high-risk category, as we just mentioned, in those cases, if they're not high risk, their initial treatment is with antiarrhythmic agents such as beta blockers or amiodarone may be used to suppress that catecholamine-triggered ventricular arrhythmias that develop. The most effective medication at this point appears to be sotalol. On the other hand, patients that fall into the high-risk category require urgent placement of an ICD. Patients with persistent symptomatic arrhythmias may consider radiofrequency ablation of the conduction pathway that's causing them. And those that develop heart failure are treated as such, meaning that they'll get diuretics, anticoagulants, and even ACE inhibitors. And remember, these ACE inhibitors can help prevent cardiac remodeling. In very severe cases, cardiac transplantation may also be required. So let's review what we discussed before we end here. So arrhythmogenic right ventricular dysplasia is a result of fibrofatty tissue, or it's going into and replacing that right ventricular myocardium. Okay, so you have these fibrofatty deposition that's filling up this right ventricle, and as a result, we can get these paroxysmal ventricular arrhythmias that develop. Remember, this reentrant form, okay, as well as that risk of sudden cardiac death as a consequence. Now, remember, we mentioned what these inherited arrhythmia disorders have in common, and the main feature that really sets them apart is their EKG pattern that we mentioned, that we'll go over shortly. Okay. Now, remember, this is typically an autosomal dominant disorder with variable penetrance and expression. There's also that autosomal recessive form that exists, that Naxos disease, where you have that woolly hair and the palmoplanar keratoderma. So those are the hair and skin changes. Remember, arrhythmogenic right ventricular dysplasia is more common in males as well as those that are Italian or Greek descent. Okay, there's no single diagnostic test. That's why we have to consider the clinical EKG and imaging findings. We talked about each of these, the clinical findings here, okay, where they can have palpitation, syncope, or cardiac arrest secondary to any physical activity or exercise. All right, these patients may also develop right ventricular failure that can lead to biventricular failure and even dilated cardiomyopathy. Now, what I want you to really hold on to are these EKG features, especially this first one that you'll tend to hear it associated with is this epsilon wave. Remember that epsilon wave is here at the end of our QRS complex, is that positive deflection there. And this is the most specific. Remember, it's in about 30% of patients. Now, other findings on the EKG that we mentioned were in those right precordial leads, V1 through V3, or the T-wave inversion, the S-wave upstroke that's prolonged, greater than or equal to 55 milliseconds, as well as a prolonged QRS interval that's 110 milliseconds or greater. And remember, we can also have these paroxysmal episodes of that reentrant right ventricular VTAC that has that left bundle branch block morphology that develops because they're going around that fatty, the fat cells, okay? So you have that fatty deposition, and then you can have this pretty much starting and just goes around, is initiated and circles around one of the fat cells and can lead to this VTAC form. Okay. Now, in terms of imaging, we mentioned echo can show that dilated hypokinetic right ventricle with the prominent apical trabeculi and dilatation of the right ventricular outflow tract. Cardiac MRI can give you more detail where you see that fibrofatty infiltration, the right ventricular thinning, dilatation, and or aneurysms. You can see that regional wall motion abnormality and even global systolic dysfunction. CT scan and right ventricular contrast angiography can be used if you don't have cardiac MRI, okay? And then remember, histology via biopsy is that definitive form to give you the diagnosis as well. Remember those patients that are high risk, this is important to remember. If they're high risk, if they have one of any of these, so the history of syncope secondary to cardiac arrest, recurrent arrhythmias that are not suppressed by antiarrhythmic medications, or if they have a family history of cardiac arrest in a first-degree relative. So any one of those can put that patient and makes them at high risk of sudden cardiac death. And you want to keep those patients in mind because the treatment will change. Well, that's the end of this lecture. We discussed arrhythmogenic right ventricular dysplasia, including its pathophysiology, clinical symptoms, EKG and imaging findings, as well as potential treatment options. I hope you learned something.